Okay. We're live. We're recording. Okay, so we're there for you guys to review other chapters, just to review them, if they're not going to be on any test. Okay. So, and hopefully this is review for you guys. So antepartum is any lady that's pregnant. It doesn't matter if she's 1 week pregnant or 41 weeks pregnant. She's an antepartum patient. Okay? Antepartum just means she's pregnant. Okay? Intrapartum is what we call women who are laboring. So again, if she's 32 weeks and laboring, which wouldn't make us happy, but it doesn't matter. If she's laboring, she's an intrapartum patient. Okay? And then postpartum is after she's delivered, and then that's a period up to 6 weeks. Okay? So when we go to OB and we take care of pregnant women, there's a lot of them who are there who are not laboring. And those are our antepartum patients. So for whatever reason, they're pregnant, they're not laboring, they're sick, they've been admitted to our unit. We're going to keep them there for however long, hopefully not laboring. And there are antepartum patients. And you will hear the word antes. Oh, the antes, the antes, the antes. And that's what they're referring to, is the antepartum patients. Okay, so gestation is what we call each week of pregnancy. Okay? We calculate that from the last menstrual period, okay? The first day of the last menstrual period. And then every week after that, she is 1 week gestation, 8 weeks gestation, 20 weeks gestation, okay? Now an abortion is any birth that happens before 20 weeks, whether the baby takes a breath or not, but usually before 20 weeks they don't do that. So an abortion is any birth before 20 weeks, whether it is a spontaneous abortion or whether it's an elective abortion, okay? So be careful with this word when you're around your patient because, oh, I see you've aborted 3 times and she's going to come out of the bed and slap you in the face because she had a miscarriage is what she had, okay? But we in the medical field call that an abortion. That's what it is, okay? And then less than 500 grams. So they could be 21, 22 weeks, but if the baby weighed less than 500 grams, we're still going to call it an abortion, okay? Yeah.
I know that miscarriages are very emotional issues for women. Is there a best practice on how you approach that? Because, I mean, you got to get that information, but how do you do it sensitively? And
you don't beat around the bush. You don't, I mean, it's not like you'd be cold or anything. I see you've had a couple of miscarriages. How many weeks were your miscarriages? And do you know what the problem was? And, you know, usually they can, you know, tell you without much emotion, but, and that's probably because she's currently pregnant and now she's happy. So, okay, here we are, thank God, we got this far. Okay. Term is any pregnancy after 38 weeks. And we say up until 42 weeks. So you'll hear different people saying what term is, what post-dates or post-term is, but the technical definition of term is 38 to 42 weeks, okay? And then so they've divided, because people are always calling it post-dates and preterm or something like that, they've divided term, 38 to 42 weeks, they've divided that into something they call early term, full term, or later term. So we just can complicate things a little more, okay? So early term is anything from 37 to 38 and 6/7 weeks, okay? And you can see full term and later term, okay? Preterm or premature is anything between 20 and 37 weeks. So if she delivers before 20 weeks, irregardless of why, it's an abortion. But if she labors and delivers after 20 weeks, but before 37, we're going to call her preterm. Okay? Or premature. Preterm or premature. And then post-term is after 42 weeks. And then, yes?
And any delivery after 20 weeks counts as para, is that correct? Even if it's a stillborn?
Right.
Okay.
Right. Stillbirth is a baby born after 20 weeks, and they do not take a breath. They do not have a heartbeat. Okay? They're stillborn. If they're born after 20 weeks and they take one breath and we detect one heartbeat, and that's it, they're not stillborn. They were born live. Okay?
Do we count those as paras just because of the changes that it's going to cause in the uterus and the cervix and all that?
Well, it's not so much because of those changes. It's more because of the definition.
Just because you got to draw a line somewhere?
Yeah.
Okay.
So a gravid woman is any woman, any pregnancy. Okay? A nulla gravida woman is a woman who's never been pregnant. And we don't usually see those women because we're a birthing unit. But they're called nulla gravidas. Primogravidas are their first pregnancy, and multigravidas are their second or more pregnancy. And you'll hear us say primip, primip, primip. That means this was her first pregnancy. Or you'll hear us say multip, 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 and that means she's had multiple pregnancies. Now, I don't know if this is a definition that we're going to come up to, but I'm just going to tell you, since we're talking about multigravida, that means she's had 2 or more pregnancies, right? But what do you think is the definition if I said she has a multiple gestation? Right. Okay. Now, a prima para is one birth after 20 weeks. So, one birth after 20 weeks. So if she's had 10 miscarriages or 10 abortions, she's delivered before 20 weeks, she's not a prima para. But if she has any delivery after 20 weeks, the first one is called a prima para. So para is a birth after 20 weeks. Nulla para is no births after 20 weeks. So she could have had several miscarriages, but never had a birth after 20 weeks. So she's still nulla para. Okay. And a multipara is 2 or more births after 20 weeks. So gravida is all pregnancies of any duration. So if she's pregnant for 1 day, she's a gravida 1, if that was her only pregnancy. Okay? So you'll see just a G, that depicted as just a G on her medical records. Or you'll hear that being given in report. She's a G1, G2, G whatever. Okay? So G is any pregnancy. So this is going to cover the pregnancies where she miscarried or aborted. Okay? T stands for the number of term infants born after 37 weeks. Okay? So if she was a G4 and she had oh, crap. I don't know how to make this thing work. Okay. So if she was a G4, so she's been pregnant 4 times at any duration, and she was a T2, that means she's had 2 births greater than 37 weeks. Okay? So the other 2, we haven't determined what they are yet. Okay? But we know that 2 of those pregnancies resulted in a term birth. Yeah.
For the T's, do you count twins as two T's or one?
Yeah. Yeah, it depends on who you ask, but technically no.
Okay.
Okay. And we'll get to that. And I say it depends on who you ask because before, ACOG and A1 and NCIHD, whatever those initials are that I showed you the strip review the other day, those people, before they all sat down, because the reason why they all sat down and did that strip, they also had a nomenclature that we always use so that everybody is saying the same thing. Because one of your biggest problems with sentinel events is miscommunication. So what I call something, you might call something totally different. So when I'm giving you a report, you're not jumping up doing something, okay, as maybe I am. So those communication errors were causing sentinel events. So these people back in 2008 or whenever that was, 2010, I can't remember, when they all sat down and they decided how we're defining things and what terminologies we're going to use, that's when they came up with all these words. Anyways, but it's supposed to make us understand each other more clear, okay? But anyways, P stands for preterm, so any birth between 20 and 37 weeks. So our gal was a G4, so she was pregnant 4 times. She was a T2, so she had 2 term deliveries. And now she's a P1 because she delivered at 36 weeks, that third kid. Okay? So she's a G4, T2, P1 so far. Okay? So we have one other pregnancy that we need to deal with. And that's where the A comes in. Well, not necessarily the A, but that's where the A comes in. Number of pregnancies that ended in an abortion. So ended before 20 weeks, whether it was a spontaneous or an elective abortion. Okay? So our G4 lady is now G4, T2, P1, A1. And so all these numbers after the G should add up. Except if she's still currently pregnant. Okay? So that's why I said that might be an exception. So our G4 lady, she did not have a spontaneous abortion. She had 2 term births, 1 preterm birth, and she's still pregnant. So she's a G4, T2, P1. Right, P1. Okay? So that only adds up to 3, but she's still pregnant, so that's correct. Yes?
So if it said G4, T2, P1, L4, then that would indicate that one of her pregnancies was twins.
Right, that's where you get the twins. Okay? And this is the argument with that scenario. So you have a G4, let's just say she's a P3, so she's had, a T3, so she's had 3 term deliveries, and she's an L4, okay? So that means she was pregnant 4 times, she had 3 term deliveries, but she has 4 living children. So that means that one of them must be a twin. Oh, but damn. One of her babies died at 6 years old. So that's the problem with the twin thing. That's where some people argue that when we say T for term, or even P for preterm, that we count each twin, each baby that comes out as its own separate delivery. Because it was its own separate delivery. You ask any pregnant woman who delivered twins, she's going to tell you, I delivered twice. Okay? But anyways, that's not how it's going to work. So L is the living children. All right, terminology, are we good?
If you were to chart that, would you include the A at all, or leave the A completely out if she's had 0 abortions?
You would say A0. Okay? And then, so the scenario where I said you have twins, but one of your children died at 6 years old, so they're not a living child anymore, but you did deliver them. So occasionally you will see, all the G, T, P, A, L, and then afterwards you'll see T, little w. and then they'll put how many sets of twins there was. So then you could take from the living, and then you could see that she had a set of twins, but it doesn't add up because there should be another child in there, and that child died at 6 years old. Okay?
I have a question about that.
Uh-huh.
Why is it important that we know how many is living?
Well, it's not so important as far as our care, our physical care of the patient. It might be important because if she did lose a child, when she delivers, now she's going to start having some emotional things about the child she lost when she's holding the new child. The other thing is, if she's had 4 deliveries and she only reports 1 living kid, and we know the other 3 are still alive. Oh no, I'm sorry. If she had 4 deliveries and 4 living children, but she only has 1 child in the house, where are the other 3? Now, I'm not saying that they died in the backyard, but I'm saying, well, so maybe they, Child Protective Services has taken the others, and if Child Protection Services has taken children, then we need to call them on this new one. Okay? So.
Is that like something you would automatically do if a parent who had previous children taken away had a baby? Would just automatically call Social Services?
Write an order for social services. So our hospital will, we have social services people, and we have a dedicated OB person. So we write an order, it gets to the computer system on her desk, and then she comes, and then she talks to the patient, she calls their CPS worker, whoever that was, and then they decide. The CPS worker comes in, and then they are making the decision on what happens with this child. We are not.
Is that done prior to the baby being born, or?
Usually, yes. Hold on. Yes, so like when she gets on her prenatal records, or maybe even the doctor will give us a heads up, we'll start that contact, or we'll put that order in now. And the CPS person is not going to come see them during labor. Worst time to try to have some kind of conversation with someone, especially about the where their baby's going to go after they are born. So they'll do that postpartum. They'll see the patient postpartum. All right. So we're going to go on to talk about the important things that are happening to make labor happen. Okay. The birth passageway or the birth canal has a lot to do with whether this baby is going to be a functional labor and whether it's going to be a successful vaginal delivery. The passenger, which is the fetus, how that fetus is in there or how big that fetus is going to tell us whether or not we're going to have a functional labor and a successful vaginal delivery. So these two things right there, well, I guess in the next one as well. If we're running Pitocin and making this woman contract, and she's not dilating, she's not progressing, then there's a problem with one of those two first things. Okay? So if I'm taking care of this woman all day, and I'm running pit, and I'm cranking the pit, and I'm expecting that she's getting contractions, which she probably is, but her cervix is not changing, which it probably should be, then I'm on the phone to the doctor saying, hey, you need to come in here. Something's not working here, and we might need to make a new plan. But the physiological forces of labor are also are important factors in whether you're going to have a functional labor and a successful vaginal delivery. And the forces of the labor are the woman's contractions. Are they strong enough to dilate her cervix? And then when she gets dilated, does she have enough abdominal muscle along with the contraction to push the baby out? Okay? So those are all important factors. the position of the woman and the psychosocial stuff, okay? So when we talk about the birth canal, we're talking mainly about the inlet, the mid-pelvis, and the outlet, okay? The inlet is when baby has engaged in between her pelvic bones, okay? The mid-pelvis is when baby is actually kind of moving down through the birth canal, and the outlet is when baby is being pushed out, okay? So we're concerned about those structures. Are those structures in the correct shape? And are they big enough to accommodate this baby? And then here's your shapes, okay? And if you look, I don't know if yeah, I do. Here's your shapes, okay? So the gynecoid shape is the first shape, and as you can imagine, because of the name, that's probably the best pelvis to have to birth a baby, is a gyne pelvis, okay? The android pelvis sounds kind of masculine, and it's not a good pelvis to push a baby out of, okay? And it's probably not going to happen if that's the shape of her pelvis. Anthropoid is just a different shape of the pelvis, and if you look at that pelvis, you can actually see a baby's head going through there, can't you? So that's a good pelvis to have a baby. And the platypoid, it's kind of flattened, so you see how round this anthropoid is, and you see how flat that platypoid is, so probably going to get a baby through that one. Okay? Now, do we know what the woman's shapes are when she comes into labor? No. We don't know. They don't check. Back in the day, maybe they used to, but the PCP does not check anymore. Okay? All right, was there a question coming over there?
I was just going to ask how you would know.
Yeah, you don't know. After the baby's delivered, you think, well, she either had a gynecoid or an anthropoid, okay? So the next thing is the passenger, which is the fetus, and is that head gonna fit? Yes.
I'm sorry. Is that something that might be evaluated for a woman who failed to progress in labor and had to get a C-section? Like,
You know, it would be a good idea for PCP maybe to check that out.
Okay.
No, it doesn't happen.
Okay.
She gets to try again
Okay.
if she wants to.
How do you have to take X-rays or something?
You would, yes, you would have to do an X-ray and do measurements, even like they do ultrasounds where they measure babies and
Yeah.
stuff. They could probably find that out very easily, but they don't. Okay.
It's the shape that you're always having. You're born with that shape. It's not going to become that shape
Oh.
when you're pregnant.
No, yes, you're born with that shape. Yep. Okay, so we need to talk about the baby's head, and is it going to get through there? And, you know, women have a lot of ultrasounds during pregnancy. Usually, if it's a healthy pregnancy, they have one ultrasound, and that's early in pregnancy, and that's just to establish dates, okay, or to confirm the dates. But women who have problems during their pregnancy get multiple ultrasounds, and they do measurements, and even if they do a measurement and the measurement says that ain't going to fit, the woman still has the choice to try, because those measurements are not exact. Okay? They're just guesstimates, the best guess we can tell from ultrasound. But anyways, when we're talking about the fetal head, babies don't have one solid skull like we do. They start out with their bones separated. So they have two frontal bones, two parietal bones, and just one occipital bone, okay? And so these bones are not fused. And so during the birth process, these bones can get squished and overlap, okay? And that's what molding is, okay? The head has molded to the shape of the birth canal to get out. Now, sutures are the spaces between all these individual bones, okay? So when we're doing vaginal exams, to try to get a feel for how baby's head is positioned in there, we're looking for those bones to try to identify what part of the head is coming through the birth canal? Is it this part of the head, which is going to be really hard to come through the birth canal? This is the military position, you know, straight down through there, like a ramrod, okay? Or is it this part of the head that's coming through there, which is the smallest diameter, and what we want to be coming through there? So we have those sutures that mold over and that we're feeling for, and then also when these bones are all sitting there, the corners or the places where they meet another bone, so these two parietal bones right here meets the frontal bones, then it creates this space different from the suture. So the sutures between two same bones, or not necessarily two same bones, but two bones paralleling each other, kind of, sort of. And the fontanelles are the corners where the bones don't all meet square, okay? So the fontanelles we're looking for when we're doing a badge exam because they're shaped a little differently. One's bigger than the other. So if I'm feeling this fontanelle, then I know my baby's coming out this way. And that's not the greatest. But if I feel this fontanelle back here, then I know my baby's coming down with the occiput, and that's the best way for baby to come down. Okay? These are also, if you heard people say, oh, look at the baby's soft spot on their head. Have you heard that? So that's what they're talking about is the fontanelles, is the baby's soft spot. Okay? And so here's what they look like. So we're feeling for these sutures, and we're feeling for these fontanelles. And you can see how they're shaped differently. This is like a diamond or a tilted square, and this is like a triangle-ish. Okay?
How do you blindly tell the difference?
Huh?
How do you blindly tell the difference between the two?
So if I'm feeling a triangle, I know I've got the posterior fontanelle. If I'm feeling a triangle, I've got the posterior fontanelle. If I'm feeling the anterior fontanelle, I'm feeling a square, or, you know.
So you're like running your finger along
Yeah,
the edges?
yeah, I am feeling that baby's head. Every place I can get to, I'm feeling. And I'm looking for suture, and I'm looking for fontanelles. Now, the thing that makes it kind of difficult is if this baby has been banging against that cervix and that pelvis, then we're going to start getting swelling on the head. So that starts making it very difficult to determine what we're feeling.
When you do what you can reach, that's just without a cervix, you don't.
No, it's in through the cervix. I'm going past the cervix. Okay, so we have the cervix sitting here. I'm coming up this way, okay, and then I'm feeling whatever's right here. If I can reach it. Like, look.
Is there a certain station that the kid has to be at before you can start doing this?
Well,
Does it just depend on
yeah,
how
so I can typically feel a baby at -2 station. If baby's at -3, I'm not really feeling it. And if baby's at -3, I might not have an open cervix because baby is not putting pressure on that cervix to squish it and efface it and dilate it, open it. Okay?
So when we're doing an exam like that, we're not forcing the cervix open. I mean, if it's not open, your finger's not going to go through, right?
Right. Oh, well, I'm sorry. Your finger can go through, but you're going to get kicked in the teeth real hard. It's painful. You can stretch that cervix open, but that takes effort on your part beyond normal checking, and I would stand there and let you get kicked. All right, so these are landmarks. Like we never use these terminologies except for occiput. We'll either say we have a forehead, or we have a chin, or we have a butt. Okay, but these are those these are the parts of the head that those are referring to. So if you're having a bregma, which I've never used that term in 20 years, but I have said military, okay? And basically that's what that is. It's straight on, head cramming through like a batter ram, okay? The sinciput is the forehead area, so when you're doing a vag exam, you're feeling this forehead. So how do you know if it's the forehead and not this part of the head or that part of the head? You're not going to find any sutures at all, okay? And you might even start feeling like you might be feeling in, oh wow, I think those are eyeballs. But the mentum, if you've got a baby coming down like this through the cervix, that head is not going to be delivered, for one, or you're going to break the baby's neck. But you'll know you've got that chin. Okay. So instead of baby being flexed like we like, this baby is like this. Okay. Vertex and occiput, you'll hear that all the time. My baby's vertex. Okay, that's great. Head down, the back of the head, that's what we're feeling. And we're anticipating that, so we're feeling kind of this part of the head, and then as that baby starts squeezing through the birth canal, it's going to, do you see how my head's coming down? So that we're getting more of this. So as baby comes down through the birth canal, baby will flex even more so that we get that smaller diameter through the birth canal. Oh, yes, I'm sorry.
If you have a baby coming through with their chin first, what do? You just like push them back up? Or?
Well, we don't, as nurses, we don't. I mean, we call the physician, we say, I have a chin. I haven't ever called a physician and say I have a mentum, because if I did, he'd be like, "You what? What? You have a what? Where'd you get that?" So I have a chin presentation. Or do you want to come in and try to do a version? So an external version. If we talked about that last semester, that's when the woman's breech and we turn the baby so that when she does go into labor, hopefully baby's head stays down. So that's called an external version. But any change and any way you change a baby's position is a version. You may not be going the whole way around, but I would need that position to reposition that head and see if we can get the vertex down there. And if he can't, or if he refuses, then the woman is almost faced with the you have no choice but to do a C-section. That baby is not going to come out your vagina. It's not coming. Okay? So anyways, the other thing we want to know, and we're just assuming until we feel a chin or a shoulder or something, that we have the correct attitude with our baby. Our babies are displaying attitudes before they're even born. But attitude is, are they flexed in the fetal position, or are they all splayed out and going to make this difficult? So this is huh? Yeah, so that's the one thing about recording is you don't get to, that's why you should be here no matter what. You don't get to see me do my dance. So this is what we want. All right? Babies are lying before we even get them out in the real world. So when we talk about fetal lie, we're talking about the baby's spinal cord related to mom's spinal cord. Are they running parallel, or are they perpendicular or transverse to one another? Okay? Or longitudinal, sorry, didn't use the right word. Longitudinal or transverse. Okay? Now, this is engagement. This is where we're talking about, is the head coming down into the pelvis? That's what engagement means, is the baby engaging the pelvis. So, when we're doing a vag exam and determining, this is where we're going to be determining station, and we'll look at a slide for station. But anything below this point is the true pelvis. Anything above is the false pelvis, okay? And then when we talk about is our baby engaged, we want to know what station that presenting part is. Whether it's the butt, shoulder, or head, it doesn't matter. We're still wanting to know what station in her pelvis is that presenting part. And yes, we do want that presenting part to be a head. But it's the very top of the head, or the very top, the thing we hit when we're doing a badge exam, okay? Where is that in this pelvis, okay? And our baseline, or our zero station, is the ischial spines. And, okay, so they're these little protrusions, okay? And when you're doing a badge exam and you go up and you find the cervix, you see how dilated it is, you decide how effaced it is, how thick or thin, then you need to decide where in relation to these ischial spines is that head. And so what I do is when I've contacted the head, I take one finger down, so I leave one finger on the head, I take one finger down, and I'm palpating the floor of her vagina to feel this little bump. Okay? When I feel that little bump, then I take a mental picture of how far I think my fingers are from each other, and I mentally imagine my fingers going between these two fingers. Okay? And then I guess what her station is. Okay? So do I have 3 fingers in there, one finger being a centimeter? So she's 3 fingers above those ischial spines, or she's -3 station. Okay? If I did my badge exam and I touched my baby's head and I could touch the ischial spines at the same time, she's at 0 station. But if I touch my baby's head and baby is coming down through there, I might not be able to feel the ischial spines. But if I kind of remember where they were in her vagina, I can kind of guesstimate how far, okay? Yeah, you're all going like, and that's exactly what it is. We're guessing, we're estimating. So my estimation may be different from yours, okay? And it's certainly different than the doc's. Yours is more accurate though, by the way. Okay?
But the point is that if you have the same person doing all these estimates, it's consistent, so you can track.
Right,
it.
right.
Is this, stupid question. Is this something you can feel not being pregnant, like the ischial spines?
Mhm.
I've never
Yeah,
even.
yeah. You've never felt your ischial spines? Oh, listen, I gotta turn the recorder off. It's not like they're very feelable, okay? So you see, they're just little humpies. Now put a bunch of tissue over that. They're very hard to find to begin with, okay? So it's not something that when you go in there, you're like, okay, turn right at the ischial spine. There it is, like a big billboard sign. It's very hard to feel, okay? It takes a lot of practice. And then sometimes when I haven't felt them, like there's lots of times I can't find them. So I just kind of guess. Baby's up there a little ways. Okay, so, okay, she's -2. Whatever, okay? If baby's up there a ways, and I say -2, and she's really -3, or she's really -1, who cares? She's not ready to deliver, okay? All right? I mean, it's not that who cares, but it's not like you can't. So these next slides are just showing this baby moving down and moving down and moving down. Oh, that's it. So station, just like we've been saying, is the relationship from the presenting part to the ischial spines. Ischial spines are 0 station. Anything above 1 centimeter, 2 centimeters, 3 centimeters, or 1 finger, 2 fingers, 3 fingers is minus station. And anything below is plus station. Yeah.
What station in our estimation is go time? Like at what point do we really care?
Well, so usually, I mean, are you talking about pushing go time? Usually they're at a +1 or +2 station, okay? Because it's not so much the station as the go time, it's the dilation.
Okay.
Okay? And then let's talk about dilation. So she's completely dilated, And maybe she is at a +1, maybe she even is at a +2 station. She has no urge to push. I'm not pushing her. I wait for her body to say it's time, okay? Some women will say it's time and they're only 8 centimeters, so I'm in there continuously trying to keep her from pushing. Because if she pushes through 8 centimeters, she's going to tear her cervix. Cervix is very vascular, and that sucker will bleed like a sieve, okay? So, anyways. All right, so here you can see a better depiction of, so at -3 station, if baby is anywhere above -2, -3 station, baby is not in the true pelvis. Baby is in the false pelvis. And you will hear people saying, oh, that baby's ballotable. So they're not down in the pelvis where the pelvic bones are squeezing the baby's head and keeping it right there. But it's up there, and you can just bounce that baby like a ball. Okay? That's ballotable. And we say, why are we inducing this woman? She's not going to, it's not good. Okay. So now we want to talk about the fetal position. And this is where it might get a little hairy, okay? So let's just break this apart slowly. When we talk about fetal position, we're talking about the presenting part, whether that's a chin, hopefully it's not a shin, a chin, a shoulder, a butt, a forehead, whatever the presenting part is, and again, we want it to be the vertex. But whatever presenting part that is, where is it facing in relation to the mom? Okay, so if I'm the mom and I'm laying like this, and the presenting part that I'm feeling is facing, pointing this way, then she's right. If I'm pointing this way, then she's left. So when you're doing the vag exam, you got to think opposite. Okay. All right. So she's either right, left, or she's right dead center, and we don't make a note for right dead center. It's either right or left, or it's nothing. Okay, and we'll see that in a minute. What is right, left, or nothing? Is it the occiput? Is it the chin? Is it the buttocks? Is it the shoulder? Okay, and that's what all these are. Occiput is the head. Mentum is the chin. Sacrum, I think that stands for butt. Sacrum is butt, and the acromion is the shoulder or scapula or something like that. Okay. So she's either. So we're breaking this down. So we're only to here. So she's either, and we're going to say our baby's occiput because that's more positive. We like to talk positive. She's either R-O, she's either L-O, or she's O, meaning she's dead center. Okay? And so it would be the same thing with these other letters, but I have never seen those other letters used in practice. Okay? If I see those other letters used in practice, I mean, if those things need to be used in practice, I will hear breech. I won't hear sacrum. Okay? And we won't care if it's left, right, anterior, posterior. It's a butt. It shouldn't be there. We need to go in a different direction. Okay? Same thing with the shoulder. I don't hear acromion. I hear shoulder. That's what you hear in practice. But please know these terms. Okay? But I'll hear shoulder. And if I hear shoulder, we're either doing a version, just like a breech. We could do a version on a breech, or we're trying to do a version, or we're going to C-section. Yes.
What about charting?
We would say breech. We would say transverse or shoulder. We just focus on this because this is what you're going to be tested on. But when we go into clinical, you're not going to see that. Okay? Yes.
I'm sure we'll see this soon, but in Cerner with the charting or on Epic, is it another list of, here's the category and then here's all the boxes that you can check?
Yeah,
And
and
they're already populated, you just have to pick.
right, you just have to pick, but those M, S, A are not options in
Okay.
our real world, okay? All right, now, after we've gotten right, left, or center, after we've got which presenting part we have, now we need to say if that presenting part is facing the front of the woman or the back of the woman. Okay? Anterior or posterior. Okay? So if I've got, now we're going to do occiput. If I've got an R and an O, so I've got my occiput, I'm feeling it facing this direction instead of facing this direction. I feel it facing this direction, but it's actually pointing also towards her butt. So it's to the right of her rear. Yes, it's to the right of her rear. Yes.
Do we use the patient's right and left?
Yes, we're using the patient's right and left. So that's why, you're doing this way, so you've got to switch, okay? You got to say, it's the patient's right. Okay? So I feel the occiput. I feel it's pointing to the right and also to the back. Okay? Or to the left, to the back, to the right, to the front, to the left, to the front. Or I feel the occiput facing directly front. Or I feel the occiput facing directly back. Okay? When you've worked in OB and have done a few vag exams, you're going to start feeling how this is correct. Or you're going to start seeing how this is easy to identify. It sounds like it's really crazy to identify right now, okay? But if I have the back of the head facing to the front of the woman, what's facing to the back? The face, okay? And that's how we want babies born, is the face to the back. Now, with the occiput. Now, they can be right or left. We're not too crazy about that. But we definitely want the occiput facing forward and or to the right or left, okay? So if we have the occiput facing forward, then we have an OA, okay? We might have an ROA, and we might have an LOA, okay? If we have an OP, that means the back of the baby's head is facing to the back of the woman's body, and the face is facing to the front. That is a difficult delivery. That is backwards from what we really want. And when I say difficult delivery, I mean this woman has to push that much harder to get that baby out, okay? Because so when we see a simulation birth, you'll see how when the back of that head comes down under this pubic bone and the face is supported by the posterior wall of her vagina and just comes up, okay? If it's facing the other way, this face is raking down that pelvis bone and that occiput is just pounding down on her rectum, and it's just like it kind of gets stuck down there in the rectum, or not in the rectum, but you know what I'm saying, like in that back floor wall of her vagina, and just kind of sits there. So push harder, I'm pushing as hard as I can't do no more. Okay, so they can be delivered vaginally, it's just difficult.
That would, they would pull out the clamps.
They might pull out the clamps and help her. The forceps or the vacuum. And we'll see some of those when we go to the OB and tour.
How often are those used, like the clamps?
The forceps are not used very often. So neither one of them is used very often, and the forceps are used less often because practitioners are coming out of training, and there's not a lot of practitioners who are skilled at the use of forceps. And so they're not getting adequate training. and everybody just prefers that little vacuum that we're using now, as opposed to that big Hoover that we brung on a cart. We did in the day. It was this big, torturous looking machine. Okay, so just summary. All our forces of labor. Oh, wow. Like I must have. I don't know. I don't know what I did. Okay. So on the list of 5 things that make labor possible, the physiological forces, so the force of the contraction and the force of her abdominal muscles. So in a contraction, there's phases of the contraction. There's the increment where the contraction is starting to strengthen, 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 strengthen. There's the acme or the peak where it's at its strongest point. And there's the decrement where it is now releasing, 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 relax. Okay? So those are the phases of the contraction. As we talked Monday, we want to know about the frequency. So we're counting from the beginning of one contraction to the beginning of the next. Duration, we're counting from the beginning of the contraction to the end of the contraction. And then intensity, if we have an external monitor, or mild, moderate, or strong. If we have an internal monitor, we can use the millimeters of mercury on the tracing paper and say how strong her contractions are. But when we do that, we need to subtract her resting tone. So let's just say her resting tone is 0 millimeters of mercury, which it's not. It's usually 5 to 20 millimeters of mercury, just resting, okay? There's always a little bit of tension in a muscle. So that would be the resting tone, okay? And we palpate the resting tone to make sure that indeed, her uterus is relaxing between contractions, okay? If her uterus is not resting between contractions, then we have a problem. That uterus is staying contracted. That means it's constricting vessels. That means we're decreasing blood flow to placenta. That means we're decreasing oxygen to baby. So we want to ensure we have a soft uterus between contractions. That's baby's recovery time, okay? So here's our increment of our contraction, here's our acme, and here's our decrement, here's our resting tone, and then here we go again. So when we're counting frequency, we start from the time the contraction starts, and we count our dark red lines to the start of the next contraction, okay? And then you do that, like in a 10-minute period, you count how far all those contractions are apart. So you have a range, because all contractions don't always hit at the same time. One may be 2 minutes apart, one may be 2.5, the next one may be 3. My range is 2 to 3, okay? Or 2 to 4, or 2 to 5, or whatever, or 5 to 6, whatever it is. And then our duration, we count the little boxes, which are 10 seconds, the light colored boxes, from the time the contraction starts till the time the contraction ends. Now when we're doing intensity, we do we palpate her during a contraction, and whatever that is, we say, okay? But if she has an internal monitor, if the top of her contraction is measuring 50 millimeters of mercury, I'm not saying her contraction is 50 millimeters of mercury strong, because I've got to subtract this resting tone from where it started its baseline. So this one says 0, so that's easy. Her contraction strength is 50 millimeters of mercury. If it started at 5, and that's her baseline resting tone is 5, I have to take 50 minus 5, and that's the strength of her contraction. Okay? Yes. Yes.
So you've talked a lot about an internal monitor. How are they placed?
So, so the internal contraction monitor and the internal fetal heart rate monitor, which is called a fetal scalp electrode. The internal contraction monitor is called an intrauterine pressure catheter. They can only be placed if she has ruptured membrane. Okay. The spiral electrode, which is the one that we screw right into the skin of the baby's head, that can be placed by an RN. Okay. But the internal pressure catheter, it actually goes through the cervix, past the baby, and lays about halfway into the uterus. We are not permitted to place those because the risk of lacerating the placenta and the woman hemorrhaging to death right there at your feet is bad for a nurse. So that's why it's the physician's job, because if he lacerates that placenta, then he's able to take her to OR. I'm not. Okay? So RNs aren't able to place an internal. But both of those are the most accurate measure of what's going on with mom and baby. Okay? But they're invasive. There's risks to them. And we don't like to use those unless we absolutely have to. Yeah?
What kind of situation would you need to use one of those as opposed to an external?
Okay, so her membranes are ruptured. I have unreassuring fetal heart rate tracings, and I'm not keeping consistent tracings. Maybe the woman is fluffy and making it difficult. Maybe she is thrashing about in the bed, and I'm not keeping the heart rate tracing. We will place the spiral electrode to keep a consistent tracing of baby. If I'm running Pitocin and she's a fluffy gal or she's moving all around like a crazy woman, and I'm not tracing her contractions, then I don't have a clue what I'm doing to her uterus with my Pitocin. So then we would want the internal contraction monitor so I can, and it doesn't matter what she's doing. Those internals will trace almost no matter what. Okay, so that's why we would use those. But they both have risks, so we don't want to use them if we don't have to. So the psychological factors, fear, anxiety, excitement, level of support. So these are really important in labor. If she's really afraid, if she's really anxious, and she's stressing all about, that is going to decrease oxygenation to her baby. That's going to increase her catecholamines. It's going to be counterproductive to labor. Okay? So we need to address those things. Okay? We need to be very supportive and nurturing, and we need to help control this woman. Feelings of joy and anticipation, great. Level of support, important thing. Like, there are some women who come in there by themselves, and they have no one with them, and no one is coming. So you are now the support person, and you could spend your entire 12-hour shift at her bedside. If she does have a support person, and they find themselves laying on the couch taking a nap, or playing Pokemon, you are the support person. I will gently suggest that you put your damn thing down and get over here. But that doesn't always happen. And then you've got the support people, and you've got this woman with this 10-page birth plan, so you're in the back sharpening knives, and her and the man, or the support person, because sometimes it's a woman, they want to do their labor thing, and they don't want you coming in as often as you cannot come in. Okay? And sometimes they want you coming in, and the dad says, help me, or I'm tired, I want to take a break, or I need to go get some coffee, will you take over? And then you take over. Okay? So we are at their disposal. So that's just a joke. So when people come in with a birth plan, it's usually not good for the RN because I can't say the word pain. I can't say the word medication. I can't say, they'll have all these taboo words. I can only say positive words. They don't want an IV, but yet they're going to hemorrhage on me. They don't want fetal monitoring, yet their baby's going to be bad. They don't want this and they don't want that, and that means that bad things are going to happen. So when we see a birth plan, we all jokingly say, sharpen the knives.
I have a question. Are women who have birth plans, are they more opposed to having students come in to their labor?
Yes and no.
Okay.
Okay, so some of the people who have birth plans, they don't even want to be in the hospital, but they're there because, yeah, okay. So sometimes they don't even want me coming in the room. So students are sometimes, but then there's the people like last semester, I had one of my students, I'm probably not allowed to say her name, but anyways, she had a birth plan patient and she spent her entire shift in there helping dad, and they loved her and it was great. So I think I need to hurry up. Okay, a love labor lecture. So causes of labor we're going to run through. Cervical dilation, effacement. So that's when the cervix thins. So if you imagine a funnel, that you change your oil with, a funnel, okay? It's got this big cup and this skinny little tube, okay? That skinny little tube is the cervix, okay? From the outside, the end of that is the external os of the cervix. The inside of that, before it becomes a bowl, is the internal os of the cervix. And when I'm talking about effacement, I want the internal and external os to become one. Okay? So this is 0% effaced. This is 20, 30, 40, 50, 60, 70, 80, 90, 100% effaced. Okay? That has nothing to do with dilation, at least as far as you're measuring. Okay? But the thinner the cervix is, the easier it is to dilate. And dilating is going from this to this. Okay, that's dilation. Effacement, dilation. Okay? All right, so you can kind of see, here's the funnel. Here's the bowl of the funnel, and here's the little spout, and we want this to thin. And then here is the external os of the cervix. Here's the internal os of the cervix.
This might be a stupid question too, but where does that tissue go? Does it go up top to help push down?
Yep.
Okay.
So it kind of, the top of the uterus kind of is drawing the cervix into its body. Okay? Okay, so here it's thinner. Remember in the previous slide, it was like this, and now it's like this, but we still haven't dilated. Okay, so the thinner the cervix is, the more easily it's dilating. So we're thinner more, and we're starting to dilate a little more.
And what would you say the effacement is on the last slide and this slide?
Okay, so this is probably maybe 50%-ish. So this is, I'm guessing again. Okay? Yes?
Can you measure effacement with zero dilation?
No, because you can't. I mean, you might feel the external funnel part, but how far it goes on the internal side, we don't know. So, so when we're talking about effacement, so she's closed thick. That's what we'll say. She's closed and thick. Okay? But for me to really accurately determine what her effacement is, I need to know what she was to begin with. And I never know that. So I'm just guessing. It's all just a guessing game. If you want to notice, I'm going to throw this in here. You see this little pocket here? That's a pocket of amniotic fluid. So this woman isn't ruptured. She's still intact membranes, and the fluid is collecting there, okay? So we can actually feel that. It's like feeling a little water balloon. And we say, she has a bulging bag of membranes. That's what that's called. It's a bulging bag of membranes. All right, so here we're thinning more, we're dilating more, and now we're completely thin and we're completely dilated. And this slide, it really, I mean, that doesn't look super thin, does it, on the slide? But I'm telling you, the thickness of your paper is 100%. And that's what it feels like, literally, the thickness of your paper, okay? Now, I'm going to turn my recording off because if I check a woman and she has a bulging bag and she's 10 centimeters and my head is coming down through the cervix and my physician will not come in and break her bag of waters, I'm going to do a very rough vaginal exam. No, you don't do that, okay? You don't do that, okay? And her bag of waters breaks and she delivers. I call the physician, sorry, dude, get in here. No, you don't do that, okay? Because what if, even though this cervix is, or this head is well applied to the cervix, and you break that bag of water accidentally, and the cord comes rushing through somehow. Now you've got an obstetrical emergency, and you're going to get in big, big, big trouble. I've never done that. Okay. I'm not going to go through these. These are very self-explanatory. I'm running here. I do want to say rupture of membranes, ROM. What does ROM also stand for? Does anybody know? Range of motion. But in the OB world, it stands for rupture of membranes. If the membranes rupture by themselves, it's called spontaneous. So you'll see SROM, spontaneous rupture of membranes. If we did it, if we broke her bag of waters, it's artificial rupture of membranes, AROM. Okay? All right. Bam. Okay. I do want to talk about this. I'm getting all sweaty. It's probably not cool out, huh? Okay. True labor versus false labor. Okay? The one thing I want to say about this is we have several women coming into the labor unit that are contracting every 2 to 5 minutes. They're rating their pain a 10. I'm in labor. Oh my God, my water broke. Guess what happened? She's having Braxton Hicks, she's not dilated, and she peed her pants. Truly, that is what happened. Okay? So, but they don't know. They did have a gush of fluid. It's true. But the contractions, or the Braxton Hicks she was having, pushed baby down on her bladder, and it squirted urine out. I am sure I didn't pee myself because I went to the bathroom and I peed and I got up and walked away and my water broke. And I do my little swab, I send it to lab, and it comes back. I'm sorry, your water did not break. It was urine. I'm sorry. But anyways, true labor versus false labor is you can contract all you want. You can rate your pain a 20 all you want. You can think your water broke all you want, but if that cervix is not dilating, you are not in labor. True labor is cervical dilation. Now, it will say back here, regular contractions increasing in frequency, duration, intensity, and that false labor does not have regular contractions that increase in frequency. They do not increase in frequency, duration, and intensity. And for your exam, that is correct. But some of these women were watching, and I'm putting them on the monitor, and I'm seeing these whopping contractions every 2 minutes, and my gal is crying. Okay? That's regular. That's increased intensity and frequency. Okay? But the cervix is not dilating. She's not in labor. So I will offer her some pain medications. I will tell her to drink lots of fluids, to go take a warm bath, and go home. Now, if her water truly is broke, then she is staying. Okay? But that's the deal.
And you determine that by what, swabbing the?
So it's called a ROM plus, ROM, ROM, rupture membrane plus. That's just the name of the thing. We do a swab in the vagina. We send that swab down to lab. They use a microscope to look to see if there's any amniotic cells. And then they tell us whether it's positive or water is broke or negative. It's not. Okay, stages of labor. First stage of labor is any dilation up to 10 centimeters. Any dilation up to 10 centimeters is the first stage of labor. Okay? The second stage of labor is when she's 10 centimeters and she's pushing the baby out. It's from 10 centimeters to birth. Okay? Third stage of labor is from the birth of the baby. Now we're gonna deliver the placenta. That's the third stage. The fourth stage is their recovery period, anywhere between 1 and 4 hours, and usually typically average 2 to 3. Okay? So in the first stage of labor, and only in the first stage of labor, not in the other stages, there's phases. Okay? Because this is the longest stage, so we broke it up. This is her actual labor. So the latent phase is the very first phase of the first stage of labor, and it's basically up to 4 centimeters. Okay? Whatever she starts at to 4 centimeters, that's the latent phase. Okay? The contractions aren't very frequent, they're not very long in duration, and the pain is very tolerable to this woman at this point, usually. Okay? That's the latent phase. Now the active phase is where all the, most of the dilation occurs in that first stage. So this is anywhere between 4 and 8 centimeters. This is the active phase of labor. This is when she's really active. The contractions are really active. They're really strong. They're really, really frequent. And she may be wanting pain medicine at this point. Okay? The transition phase is from 8 to 10 centimeters. And if this woman does not have an epidural, you can tell she's 8 to 10 centimeters by the way she's acting. We say she's in transition, like she is freaking out, okay? She's shaking uncontrollably. She's starting to get panicked. She's starting to act really psycho crazy, okay? She's transitioning. She's in the transition phase, okay? What's that?
Like a werewolf?
Yeah, like a werewolf. If I see a woman in transition, if I checked this woman an hour ago and she was 3 centimeters, and I walked back in the room because the husband called and said, she left the room and there's something else in here. Come look. If I walk in the room and I see those behaviors, I'm putting a pair of gloves on because she just went to from 3 to complete in an hour. Okay? Yes.
Does the provider or the nurse deliver the placenta?
The provider. I have delivered a lot of babies in my life, and I've only delivered 1 placenta, and because I had no choice. I prefer never to deliver a placenta, because that thing can tear and bleed, and she can hemorrhage right then and there. Okay? I'm okay with babies. I don't like placenta. Okay? Look through this cardinal movement. This is talking about how the baby's head, so the baby's in right at the true pelvis. Okay, how does the baby move and turn and get down into the pelvis, under the pelvis bone, and out? Okay, that's what cardinal movements are. So look through those. I'm not going to, so here's a picture of how baby just kind of turns, comes out, and then turns back again. Okay? So when baby's turning their head down here in the pelvis, they're turning to make the very round skull fit in the very kind of oval passageway. So they're doing this to decide which way is the best to get down. And then they get down here to the pelvic bone, and then they have to push that head up over it. So sometimes they're coming out of this vagina and they're like this way. And then they start turning, okay? And the reason why they turn is because we don't want this coming straight down through the pelvis. We don't want this coming straight down through the pelvis. We want this coming down through the pelvis. So as they come around that pelvic bone and start coming out, then they kind of twist to get these through. Okay? Those are cardinal movements. All right. Here we go. Last one. Oh, good. There's only 18 slides. We can do this.
Yeah.
Okay, so reiterating. Go. This is why I don't go over every single thing, everything in the chapter. I expect you to know everything in the chapter. If you have questions on things that I do not cover in class, you need to get in contact with me, okay? Because I'm only going over some things. Okay, so our woman has presented to labor and delivery, and she indeed is in labor, okay? She's in true labor. So we do an admitting history. We cover her obstetrical history, current and previous ones, health history, surgical history, family history, allergies, medications, everything you would do on anybody who's admitted anywhere in the hospital, okay? We do our head-to-toe assessment on this woman, okay? We do a psychosocial history and status and cultural assessment, okay? This is where we might identify that this woman doesn't have custody of her other kids. Or this is where we might identify that the woman came into labor and, oh, by the way, my husband's been beating my stomach the whole time, okay? This is where we find out these things, okay? We can't miss them. Cultural assessment. In OB, and Ginger will tell you, in pediatrics, ask about it, okay? Because there's birth practices that people from other cultures do. There's things that other cultures in general don't want happening to their bodies, or whatever, okay? So we need to ask about this. And if at all possible, we need to make that happen for them. Okay, so we get them admitted, we do all of our history. We start laboring this woman and assessing her cervical dilation and effacement. We do that on admission so that we can get a baseline, and then we can continue to assess it throughout the labor to see how we're going. We do our fetal station, our fetal assessment, where we determine station, the position. So is it OA? Is it OP? Is it breech? Is it whatever, okay? Leopold's maneuver will help us identify that, okay? But we're not always accurate with Leopold's maneuver. Like, we can do a Leopold's maneuver, and if we've got a very fluffy woman, or if we've got a woman who's normal weight, but she's got a whole ton of fluid in there where we are having a hard time getting to the baby's outlines, okay? Fetal heart rate assessment, we determine her membrane status. When we determine her membrane status, we're not only wanting to know, is she ruptured or intact, but if she's ruptured, what color is the fluid? And how much fluid is there? And is there any odor in the fluid? Because if there's odor, if it's anything but clear fluid, no odor, then we could potentially have a problem. If we have green fluid, what does green fluid mean? Does that mean infection? Meconium. So baby had meconium in utero. When babies have meconium in utero, that means they're stressed already, okay? So we can still deliver that baby vaginally, but we need to have the NICU team and a pediatrician at delivery to immediately intervene for that baby if we have to. And immediately intervene means baby has aspirated meconium, or we want to get to that baby before it aspirates. So we're going to visualize vocal cords, suction them out, and then we want to do that before baby takes their first breath. So we got to deliver this baby, get it over to the warmer, intubate, visualize, suction before that baby takes their first breath. Most of the time what happens is we have all this meconium, we're expecting this bad baby, and this baby is sitting on the perineum with the head out, screaming her lungs out. Too late, we can't do anything. And if they're screaming their lungs out, they're not sick. Okay? All right. If the fluid is not green, but it's not clear, it's got an opaque, stinky look to it, infection. If the amniotic fluid is infected, the baby is infected. Now, we can give antibiotics to treat the mom and the baby for infection, but that infection is going to stay in the amniotic fluid because there's no blood supply to the amniotic fluid. So there's no way those antibiotics can get in that amniotic fluid and clean up that infection. So we will maybe labor this patient, but if mom spikes a temp, if baby spikes heart rates or has bad heart rates, we're going straight to C-section. That means if baby does those things, baby is infected. We need baby out, and we need baby on antibiotics, because when a baby gets infected, they can go from infection to dead in 6 hours. Okay? Okay. We palpate our contractions. If we're using electronic monitoring, we can either do intermittent monitoring or we can do continuous monitoring. Intermittent, all that means is this woman has no risk factors. She's laboring just fine. She wants to get up and walk around. She wants to sit in the jacuzzi tub, but we don't have to monitor her while she's doing that. But we do have to monitor at our required monitoring periods, which is usually 20 minutes every hour. But it changes depending on what stage of labor she's in. But if she's a high risk anything, she's continuous monitoring, period. If she wants to get up and walk, she can still get up and walk. We have portable telemetry monitoring machines she can walk with. But that's only if baby's okay. I can't let a woman walking around, even on continuous monitoring, if baby's having late decels and minimal to no variability. That ain't happening. You're staying in bed. Okay? All right. We can also, so those patients with a 10-page birth plan, they don't want on fetal monitoring. They don't want any straps at all. Okay? Then I have to do this, auscultate. I have to go in with my little handheld, portable, little ultrasound. I have to listen to contractions and listen for the fetal heart rate and palpate contractions at the same time. I could be doing that for 10 solid minutes, every 30 minutes or every hour. It's so laborious to take care of these patients, but it's also fun. But anyways, so there's that, okay? Psychosocial, very important. I don't mean to skip over it like it's not, but I'm going to. Culture, okay, so we need to ask about these things. All right, I can probably slow down a little bit.
Deep breaths, happy thoughts.
Okay, so this again is about the first stage of labor, those 3 phases in the first stage of labor, okay? The latent phase is the beginning of her labor. She's not contracting very often. They're not lasting very long. She's 0 to 4 centimeters dilated. Probably does not want pain medicine, but typically I get gals in there that are 2 centimeters contracting every 5 minutes, rating their pain a 12, and they want pain medicine right now. And so I call the physician. I'm like, she's in the latent phase, contracting every 5 to 10 minutes. She wants pain medicine now. And he will very well say no. Because if we give pain medicine now, then we're going to relax those contraction pains. We're going to relax the uterus. It's not going to contract very well. It's going to space out. It's going to prolong her labor. But she demands pain medicine. All right, we're starting to pit.
How is a woman able to push with an epidural?
So there's the bottom of the perineum doesn't get epidural numbing. So there's a lot of trial and error before they get to the perineum that we push with them. Okay, the doctor's not there, it's the nurse. So I'm doing a vag exam and I'm watching her feeling as she's pushing. And I say, no, not like that, try something different. Oh, just like that. Do that every time. Because sometimes they don't know what they're doing. They know how they're doing it differently than the previous time, but they're not actually feeling that difference. Okay? So if I'm there saying, that's no good, oh, that's good, okay? So that's where we're at. But anyways, in the latent phase, usually these gals don't need pain medicine, but in the active phase, their contractions are very frequent, very regular, they're lasting a lot longer, and they're very strong, okay? And so they're 4 to 8 centimeters, all right? Transition is those contractions are right on top of each other, they're lasting a long time, this woman is freaking out if she doesn't have an epidural, and so you can actually see this phase. Yes?
Can you go back a slide?
Uh-huh.
So it looks like in transition phase, there's very little rest time for the fetus.
Mm-hmm. Right. So every 1.5 to 2 minutes. Now, we're pretending like this woman doesn't have any Pitocin, because there's nothing I can do about every 1.5 minutes if someone's not on Pitocin. But when I'm running Pitocin, I cannot allow her to contract any more frequently than every 2 minutes. So if I'm running Pitocin and she's contracting every 1.5 minutes, I'm turning the Pitocin down. I can't do this on purpose, okay? If I do this on purpose, I'm setting baby up for failure, and I'm setting myself up for a lawsuit.
Call the physician and say, I want to turn it down.
I don't have to call the physician. The physician has ordered the Pitocin per nursing protocol. It's all me. It's all you. You're the one deciding whether or not to turn off the Pitocin. You're the one deciding whether or not you can restart the Pitocin. It's your decision.
And that's 2 minutes from the start of a contraction to the start of the next, right?
Mm-hmm. And if you've got 2 minutes, then you're okay. But you get any closer than 2 minutes on Pitocin, you need to start intervening, okay? Because that's too much. So when we do a vaginal exam, we're checking effacement, dilation, station, and presenting part every time. I'm not expecting that my baby is going to go from vertex to breech during labor, okay? But I want to see how that baby, those cardinal movements are progressing appropriately. Is my baby even coming down into the pelvis? Do I have the same presentation that I had 5 centimeters ago, and that baby is not engaging? Is there a problem? And that's when I would call physician to come in and do something about it. Okay. Now, when I do vag exams, whether the patient is on Pitocin or not, I don't do vag exams every 2 hours like some people do. Okay. I do my vag exam on admission. And it is okay, it is within your scope and your decision to say, I'm going to check you every 2 hours. But if you don't see the need to check, why do you see the need to check? Do you understand what I'm saying? Like, even if you're running Pitocin, people like, well, I want to know if my Pitocin's working. I'm like, well, are you having contractions? It's working. But is it functional? So I don't check every 2 hours. I might check every 4 hours. If I've been running Pitocin and I'm continually increasing my Pitocin, I'm concerned. If I have to keep increasing my Pitocin to get her in a contraction pattern, I am definitely concerned that I'm not changing the cervix. Okay? If I have my Pitocin on a rate and I have kept it there for hours and hours and hours, I want to check to make sure that it's working. But I don't do it every 2 hours. Okay, that just sets baby up for potential infection. It's uncomfortable to mom. And I only check when I feel like I need to. And if baby's heart rates tell me I need to, then I need to. Okay? So in other words, if baby's having bad heart rates, I want to check to see what's going on. So these next slides are telling us how often we need to monitor baby and contractions. So if I'm auscultating with a Doppler, that is that little handheld device, okay, for women that are low risk, which is a very small population, I have to go in the first stage of labor, so from 0 to 10 centimeters, I have to go in every 30 minutes and auscultate for 10 minutes and palpate for contractions. In her second stage, when she's pushing, I need to do this every 15 minutes. if the woman is high risk, and I'm just going to say, if she's high risk, I'm putting her on continuous electronic monitoring. But if she's high risk, I'm doing this every 15 minutes. Every 15 minutes, I'm auscultating for 10 minutes. She's on a continuous monitor. Okay? In the second stage, it's every 5. This stuff went over everything. Wow, I hurried for. I did it. I hurried for nothing. Those slides went over fetal heart rates. Do we want to review fetal heart rates? We have time. Are you guys? You want to look over those again quickly?
Sure.
Yes.
If you're trying to do it manually, right, with the Doppler and palpating the uterus, how do you record what you're seeing if both of your hands are full? Do you have to get another nurse to come in? To
No,
help?
you just do your observation for 10 minutes, and of course you have to have some capacity for memory, because then you'll go at the end of the 10 minutes and chart what you see. Okay.
So when I was at my OB, the woman that I was watching kind of like, her baby came out head first and then had an arm come out and it got stuck in it. And they were really to duck shoulder. Can you just explain to me, I mean they explained it to me and it made sense, but
Okay.
why are we worried about that position? Is it cutting off something?
So what we're worried about is what's called shoulder dystocia.
Yeah.
So we can get the head born, but those shoulders, even though we turn the shoulders from this way to this way, we still may have these lumberjack shoulders that can't get under the pelvis, right? And that is an obstetrical emergency shoulder dystocia. So you hit the stat button and you've got 12 people in there, and we're manually, so like it is truly like putting a square peg through a round hole. It ain't coming, okay? But the head's already been delivered. And when we identify shoulder dystocia, we identify the head doing turtle movements. The head comes out, sucks back in. The head comes out, sucks back in. Right then and there, shoulder, hit the alarm, okay? And so we need to manually reduce that shoulder. And so what we do, so the shoulder's in there, here's the pelvic bone, ding, 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 okay? We lay the woman flat. Dad and another nurse are taking those legs and putting her knees to her ears as best we can. That opens the pelvis up a little bit. And then the nurse is taking her fist on the pubic bone. And she's pushing down, and the physician will say, this way or that way. And what he's saying is, which way is the baby's face facing? The baby's face is facing this way or that way. If the baby's face is facing this way, then I'm pushing down and I'm trying to fold those shoulders even more. So I'm pushing down, and then if he says this way, I'm pushing down and that way. On the suprapubic. Okay, that's very important. I'll tell you in a minute. But I'm trying to collapse those shoulders. And if I break a clavicle to get that baby out, that's what I need to do.
So they're worried about oxygen?
Yeah, so a baby's stuck in there, in the pelvis. That cord is being compressed. That is stopping blood flow and oxygenation to the baby. Okay? So I do that, I do that, I do that. I can't do it, I can't do it, I can't do it. The physician will actually reach in her vagina past the head and grab those shoulders and try to corkscrew them out. That doesn't work. Then we are running to the OR. Running, because this baby's oxygen has just stopped. Okay? We're running to the OR. If we happen to have an epidural, great. If not, and if anesthesia isn't standing there to put the mask on, to put her out, we're cutting her. Okay? And then someone is under the surgical drapes, pushing baby back up into the uterus. Don't you want to work in OB? So this is the same. This is the same thing with a cord prolapse. It's basically the same thing. However, with a cord prolapse, you can't So with a cord prolapse, you would think that you could push the head up a little bit and shove that cord back up in there. You can't, because as soon as you push the head off the cord, the rest of the cord keeps flowing out. Okay? So you're going for a little ride. You're sitting in the middle of her legs with your hand on that fetal head, pushing that head off the cord so you can at least get some blood supply to the baby. And then you're going to OR. And then when they drape her surgically, sterilely, you're still there. You're now down there, okay?
Under the drape.
Under the drapes, in her crotch, until they cut and pull the baby out. And then you can get out. Yeah. And I'm not ashamed to say, I did eat a mouthful of amniotic fluid. So,
You hazard pay
oh. But I'm okay. I just brushed the enamel off my teeth. And so these are horror stories. They're not often, but you will do, as an OB nurse, you will do competency simulation drills every year as if it's actually happening to a simulation mannequin that will actually have a baby with a cord hanging out. And you're actually going to do all these things, and you're actually going to get pushed into the OR room. You're actually going to do all these things so that we stay competent, because these things don't happen often.
So a prolapsed cord at any time is going to be a C-section right away. You can't get the cord back in. You can't carry on the pregnancy with the cord out.
No. So those are just some of the horrors that can happen in OB, which thank God they don't happen all the time. But I have cut women in her labor room with no anesthesia. I mean, I haven't. I've been the nurse with the physician. This was in Podunk, so if it's gonna go bad, it's gonna go bad in Podunk, where you don't have 24-hour anesthesia and you don't have a surgical crew. Okay? So this happened in Podunk. Physician broke the water, and thank God it happened immediately, and it wasn't just a slow physician made it out of the hospital. It happened immediately. I screamed for the physician. She ran back in, and heart rates were in the 40s. What's the normal heart rate for a baby? They were in the 40s for 7 whole minutes. We couldn't get pressure off the cord. So usually if you get in there and you push that head off, you can get pressure off the cord and get a normal heartbeat back. We couldn't get it back, and that's why we cut her there.
So at that point, do you just forget sterile technique?
Oh yeah, yeah.
You just grab
She grabbed a scalpel. She called for a scalpel. You know, everybody came rushing in. I'm doing that. We're yelling for help. My boss came. The manager of the unit came in. The manager of the unit at the time, she was a locums manager, so she was just filling in until we hired someone permanent. 300-pound woman from Africa. She lays across this woman's chest. Physically lays across her chest
to hold her down.
and holds her arms above her head. Okay, I had someone holding one leg, someone holding the other leg, as I'm holding pressure. So that's 1, 2, 3, 4, 5. 5 people at this woman's bedside. Okay, and then we were doing the cut, and the physician was yelling for lidocaine, get me something. And then the anesthesia person came in, and go get propofol or Versed or something. Go get something, and then cut. Baby was delivered. We did a few minutes of resuscitation, and baby and mom were perfect. But the terrible thing that happened, not the terrible thing, but the unfortunate thing that happened was, right before the physician came in and broke water, the husband went to go feed the dogs. And the patient's mother was there. So she's standing back there in horror, and we had someone back there with her. And then after we got baby out, then we moved mom to OR, put her to sleep, stitched her back up. But the mother owned a really nice steakhouse in town, one of the fancier steakhouses. So we all got free dinner. Yes.
So something like that, being with limited oxygen for like 7 minutes, like does that impact brain development?
Well, so no oxygen definitely would for 7 minutes, because you have 4 to 6 minutes. Okay, that's kind of the golden minute-ish. Okay, but baby was getting oxygen, even though it was decreased. So everything was shunting away from everywhere except the vital organs. So everything baby was getting, even though it was limited, was going, straight to the brain, straight to the heart, and to the adrenals. So, yes.
Are C-sections supported by L&D or perioperative nurses?
In some facilities, it's perioperative nurses, and others, it's the OB nurse. So at CMC, it's perioperative nurses. Actually, at CMC, the OB nurse circulates the C-section, and then the patient goes to recovery room to recover at CMC. At St. Pat's, the OB nurse circulates the C-section and recovers the patient.
What is circulates the patient?
So in an operating room, you have a circulating nurse, and she's basically there as one, a gopher, and two, to protect the sterile field. And then if, resuscitations or things like that need to happen, then she's there, okay? You have the surgeon, and sometimes a surgeon assists, or sometimes it's a scrub tech assist, but then you have the scrub tech there, and then we have a baby nurse there on normal deliveries, okay?
Is it a peds nurse or another L&D nurse?
It's another L&D nurse. So there's that nurse, there's the labor patient's nurse, and then the surgeon and the scrub. Now, if we're expecting something bad, and anesthesia. Oh, don't forget anesthesia. He's an important guy, or girl. If we're anticipating problems with baby, then we'll have NICU there. All right. The class is officially
Don't we have
dismissed.
paperwork? We're supposed to give a turn in.
Oh, do you guys have paperwork?
Over with you?
Yes? Okay, sorry.